welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today, we welcome back on the show Richard Anderson. He is an oncologist as well as chairman and chief executive officer of the Doctors Company, which is the nation's largest physician-owned medical malpractice insurer. He wrote the Kevin MD article, Mitigating Risks from Care During COVID-19. Richard, welcome back to the show.
Thank you very much. Nice to be with you.
So we'll get into your article in a little bit, but for those who didn't get a chance to listen to our first episode, can you just briefly share your story and journey to where you are today?
Well, sure. I'm a medical oncologist. I practiced medicine in San Diego at Scripps Hospital for 25 years. I've served as chief of medicine at Scripps Hospital, was a clinical professor of medicine at UCSD, and ultimately I was insured for 30 years by the Doctors Company, and ultimately one thing led to another, and became ultimately chairman and CEO of the Doctors Company. So it's a very different role, but it absolutely represents an advocacy role for the profession, and it's something that I feel very privileged to do.
All right, so let's jump straight into your article, because this is a topic that a lot of physicians are concerned about, especially during the pandemic. So your article is titled Mitigating Risk from Care During COVID-19. Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
The COVID pandemic is obviously extraordinary. It's a once in a lifetime event in our lives, although we may see more of these things in the future. But the initial thought has to do with COVID and all of the direct effects of COVID in terms of the care, the interruptions, the death, the morbidity, the massive overstretching of hospital and personnel in trying to treat these literally millions of cases. But there's another part of the epidemic too, which is that routine care, normal, was largely interrupted, and where it wasn't completely interrupted, it was almost universally disrupted. And we know how profound that disruption was if we look at total deaths during the pandemic year, as opposed to deaths that are directly attributed to COVID. First of all, I think we underestimate direct COVID deaths because, especially in the beginning of the pandemic, a huge number of people who had COVID weren't tested for it, so could never know for sure that they had COVID or weren't documented in our statistics. Many people and that would include even deaths, a number of people who died at home, for example, weren't be part of the statistics. So we're undercounting COVID. But if we look at it another way, we'd say, what were the expected number of deaths in the United States, say in 2020? It turns out that there's 400,000 or 500,000 additional deaths in 2020 that cannot be accounted for even by extrapolated values of COVID, meaning that other diseases were causing more deaths in 2020. And the reason for that almost surely is the disrupted care related to COVID. This article really focuses on that disruption, what the consequences are, and what our responsibilities and what good medicine looks like as we emerge from the worst aspects of the pandemic. And medical facilities are almost universally open where they're not overstretched by third and fourth waves of COVID, but we have almost a full year's worth of deferred or disrupted care to think.
Can you give an example, story, or a case study of a potential litigation risk because of some of the issues that you mentioned? Say if I'm a specific physician, maybe even a primary care physician like myself, what are some of the specific risks that we have to be careful of? Do you have a story or a case study that you can share?
I'll start with oncology since I'm an oncologist, but if we think of two areas of screening which we know to be effective and we know to save lives, mammographic screening for breast cancer and colonoscopy or other forms of screening for colon cancer. The National Cancer Institute estimates that we'll see more than 10,000 deaths because of lack of screening or disrupted screening in 2020. So that's an extrapolation, very large number of additional deaths. But the real question is, if your patient wasn't screened during that period of time, first of all, it's important that you make contact with them again. Obviously, in the midst of all this pandemic, there's a lot of movement. Patients are changing, doctors' practices are changing, lots of things are going on. It's important to reconnect with your patients who require these screenings to make sure that they get caught up with their screenings. And I think those are relatively obvious examples. But as you know, 5% of chronic diseases cause about 50% of medical contact. So if we think of patients with, for example, insulin-dependent diabetes or labile hypertension or coronary artery disease, many of those patients weren't being seen as regularly in 2020 as they would be now. And many of them will require readjustment of their doses or their medications. And it's important that we not lose track of those patients. There's one other one, which is, I think for doctors, a pretty painful subject. I mean, this notion of resistance to vaccination, which is really one of the true medical miracles of the 21st century, is hard to credit. Yet in our crazy litigation system, a doctor who doesn't reach out to his or her patients who chose not to be vaccinated has a responsibility not only to inform them of the benefit of vaccination, but to inform them of the risks of not getting vaccinated. In our politically charged environment, this seems like a counterintuitive thing to do, but from a medical point of view, it's actually quite important. We can go back a couple of decades, and there are chilling cases of women, for example, who for whatever reason refused to have the doctor said, if you don't want a pap smear, I won't give you a pap smear. But then there was litigation from women who went on to develop cervical cancer saying, you didn't inform me of the risk that I was taking by not having a pap smear. So those are the kinds of things that I think we need to be concerned about. One thing I would say, though, is that, and this is easier said than done, because medical care is still disrupted. Even though offices are open, there are only so many patients that can be seen in a day. And there's an awful lot of care that's now coming back into the office. And there are pressing procedures that didn't get done that need to get done, and those move to the head of the line. But ultimately, if we follow the normal principles of good practice, staying in touch with your patients, communicating, making sure that follow-up is actually done when it's necessary to be done, and making sure that when tests are ordered, we review the tests and take action if the test indicates that it's necessary. So we're not saying we need to do anything different, but we are saying we need to really come back to the fundamentals of primary care, long-term care, and take some responsibility for making sure that we can help our patients manage through the disruptions in their care that were caused by the pandemic.
So you mentioned reaching out to these patients who may have delayed screening due to the pandemic as one way to potentially mitigate the risk. Any other ways that physicians can mitigate that risk? Perhaps documentation, acknowledging the pandemic? What are some other ways they can do to help mitigate that risk?
You said the key word, documentation. I mean, I think, proactive reaching out and making contact with patients on your books who you know need to be seen, who haven't for whatever reason made an appointment. And it is absolutely critical to document this. It's easy for a phone call made by an assistant not to get documented in the record, or a card or a letter that was sent out not to be documented in the record. But we know that about a third of all medical liability cases are related to diagnosis, and virtually all of those are related to failure to make a diagnosis. And this is the situation where we can fail to make some diagnoses. And when a case comes to a plaintiff's attorney, the first thing that they're going to look at is they're going to look at the medical record on a delayed diagnosis case. And if that medical record is replete with references that we reached out to the patient, we asked the patient to come in, we told the patient to come in, we communicated that they needed this test or that test, or just to be seen in the office, and that is documented in the record, there's no reason for the plaintiff's attorneys to be interested in a case like that. But where they come in with a patient who says, my doctor missed my diagnosis, that's a much more attractive situation for a plaintiff's attorney.
Of course, during the pandemic, virtual medicine came to the forefront. Are there any litigation risks that arise from the increasing use of virtual medicine during the pandemic?
Yeah, that's a great question. I will say this, Doctors Company has been sort of at the forefront of telemedicine. We've been ensuring it for the better part of the decade. And of course, that was before COVID. But we've seen, it's been actually a quiet area of litigation, and we've not seen any increase yet. But again, it comes back to documentation. Telemedicine in some ways has some built-in advantage. I mean, it's not hard to create a video record of all your telemedicine, and that can be extremely valuable in the case if there's litigation. So you have a video record, which is really helpful. The other thing, though, about telemedicine, obviously, on the one hand, it's a tool that we're going to be using forever. It's an extraordinarily good tool, but it pretty much state of the art today, or not state of the art, but the way it's commonly used, there's virtually no physical examination. Now, 5 years from now, that's going to be different, right? Because we're getting digital tools. You'll be able to do the physical examination with your iPhone. You know, you put your thing on your chest, heart sounds will be analyzed digitally, so on and so forth. You take a picture of your tympanic membranes, a million different things that will be done so that there'll actually be a pretty good physical examination that'll be possible remotely. But right now, it isn't commonly done that way. And that obviously is a challenge for telemedicine. So we need to use it in most situations. It needs to be used really for screening, triage, actually a better word than screening. It needs to be used for triage. Simple solutions can be given certainly over telemedicine. But if there's a real question, it's going to require an in-person visit. It's going to require a follow-up. It's going to require some testing. And that's the part of telemedicine that we need to constantly keep in mind. It's a miracle of modern technology, but we need not to be seduced by the slickness of it and remember what its current limitations are.
We're talking to Richard Anderson. He's an oncologist, and he's the chairman and CEO of the Doctors Company, which is the nation's largest physician-owned medical malpractice insurer. Richard, I always ask this question when I talk about medical liability. What's the most common mistake that you see physicians make when it comes to protecting themselves against potential medical liability?
Well, the single most common is inadequate documentation. The most common generically, and when I say inadequate documentation, in other words, you gave informed consent verbally, but it's not written down, or you told the patient that they needed this test or that test, but it's not written down. You referred a patient for a consultation, but it's not formally documented in the chart. But more broadly, I think the majority of medical malpractice litigation is not based on the esoteric aspects of medicine. It's not based on complex care or clinical problems that were very, very difficult to solve. Some cases are, of course, but the majority aren't. The majority are blocking and tackling. It's making order a laboratory test, make sure you screen the laboratory test. If the laboratory test is abnormal, make sure you're following up on it. Same thing with x-rays, with other studies. If you refer a patient for, let's say, a surgical consultation for a mass, a lump in the breast, make sure the patient has the consultation. Make sure that you communicate with the surgeon so you know what the next steps are. It's those kinds of things which require that extra effort. They require that extra step. And they're especially difficult, I think, to achieve in today's medical environment. Patients are in transition. Many patients are and need to move around at the behest of their insurance companies rather than choosing their doctor freely, so that the doctor-patient rosters are changing constantly. It's really critical to do the blocking and tackling that all of us would recognize as good medicine. But when we're seeing 20, 30, 40 patients a day, it is very, very difficult to keep all of those balls in the air. It requires thoughtful organization of your practice. It requires having good medical assistance and a good office process. And those are things that kind of medical management isn't what any of us learned in medical school. And it becomes even more important today because of the remarkable and extraordinary stresses that all of us in practice today face.
And my final question, what's your take-home message that you want to leave with the Kevin MD?
My take-home message is, number one, I as a citizen and as a patient am grateful for the extraordinary care that's been provided by people that working through the epicenters of the pandemic. We talk about heroes all the time, but this is a generation of physicians that created an extraordinary number of heroes during the pandemic. My second message, we've gotten through the worst of it, I believe. We're making enormous strides against COVID. That's terrific. But there's an incredible reservoir of care that's been delayed or disrupted, and we have to be sure that we turn our attention to that problem.
Richard, thanks again for coming back on the show and sharing your time and insight.
Thank you very much. It's a pleasure.